probably everyone's here. We might get a few people join in a bit, but I think we're going to start. So, Dan, over to you.
Thank you, Lauren. So I can I just briefly pass over to Sarah from Unicef, just to say a couple of quick words.
Of course, thanks, Dan. Apologies again, everyone, if you hear screaming in the background. It is my daughter still refusing to go to sleep. I'm here because I'm working very closely with Gordon internally within Unicef UK, who heads up our high value and our innovation space. We launched Vaccinaid in March this year, which is a project that I'm leading on, which is our UK response to fundraising for the COVID-19 emergency need in light of the distribution of vaccine and procurement of vaccines across the world. I'm also really thrilled to be joined by Dr. Imran Mirza. So firstly, huge apologies that Dr. Ephraim Lamango isn't here today. He's actually just had a baby, so he's on paternity leave. Dr. Mirza has been one of our leading health specialists for around 8 years and has more than 18 years of experience in public health management, and is a medical doctor himself and an epidemiologist. Predominantly before moving on to working on Azzai and COVAX, he has been heavily involved in representing UNICEF globally in the international coordination groups around immunisation, specifically for meningitis, cholera, Ebola, and has himself worked in Afghanistan, Lebanon, Somalia, and Pakistan. So comes with a huge wealth of knowledge, and as I said, is one of our leading health specialists around the current pandemic that we find ourselves in. So yes, that's it from me, really. It's a huge thanks. I'm really looking forward to this evening.
The purpose of this evening, so to learn more about the global vaccination effort, and most importantly, with a view to exploring how to become involved in support of it. So thank you all very much again for being with us, and I hope it's an educational and inspirational evening. And over to Lauren and to Sarit. Thank you.
So despite the immense challenges this year has brought, in the UK, an incredible 60.9% of us have been double vaccinated, which is in stark contrast to 8.9% of people in India and just 1.3% of people in Ghana. I think this pandemic has highlighted how interconnected our world is, and with the same drive that motivated us all to join the Azzai program, we hope this evening we will come together to learn, to discuss, and to make plans for what we can do in our communities to support the work of UNICEF and Vaccinaid.
So to kick off, we would love to hear a brief overview of your career, Dr. Imran. And as a group of current students and recent graduates, it would be great to hear a bit about your journey and something that you are interested in or enjoy doing outside of work.
Thank you, Sarit. And first of all, I'd like to also thank. It's a pleasure to have on this one call with all the such dedicated colleagues and everyone. So you mentioned that, yeah, I'm a medical doctor by my profession, and I did my Master's of Science in Epidemiology. So I started my career first with the public service through the HIV program, and working in Pakistan, where I'm a national of. Then from there, after doing my MSc, I joined WHO, World Health Organization, and served almost 6 years in Afghanistan during the previous regime of the Taliban and the post-Taliban. Then from there, I moved back to Pakistan during 2015 earthquake in Pakistan. And from there, then I moved to Lebanon, and from there to Somalia. And from Somalia, I've moved here to New York headquarters. So I've experience of working, and this is, I will say, every emergency, every program is different. So it's not only the public health, it's how you deal with the complex emergencies and how you are going to do. So COVID, when it started last year, one of our thing is how we are going to tackle that one. So that is a brief summary from different countries and different environments. And that's my career brief at the moment. Thank you.
Thank you so much. So could you please tell us a bit more about the COVAX program and the role that UNICEF has within this program?
Okay, as you might know that if you have heard this COVAX, COVAX is at the moment is a unique global collaboration to handle this pandemic. And this is a collaboration between Gavi, WHO, UNICEF, and CEPI. And main objective of the COVAX is to ensure that every person in every corner of the world will have access to the COVID vaccines. And they are available regardless of their wealth and where they are, geography, and who they are. So there's one of the, and the COVAX is part of the bigger access to the COVID tools accelerator program, which is beyond the vaccine, is also to provide the treatments and the diagnostic, because without all those three components, it's very difficult to stop this pandemic. So that COVAX is one of the component on that one. And this is bringing together the governments, global health organizations, manufacturers, scientists, private sectors, everyone in bringing it to have that, to achieve that goal. And UNICEF, at the moment, you may know that UNICEF is working in about 190 countries and has spent more than 75 years in building unprecedented global health support systems. UNICEF runs the humanitarian supply warehouses in the world. UNICEF immunizes almost 45% of the world children every year, because UNICEF is a major component of the children immunization. And UNICEF is probably the only organization with the infrastructure, experience, expertise already in place to make these things happen, because UNICEF is based in 190 countries with 145 countries with the programs. So it is a grassroots level organization which is all over the world. Currently, what UNICEF is doing is providing the critical supplies and financial technical support to prepare for the COVID-19 vaccines rollout by fine-tuning and supporting the countries in developing their national vaccine deployment plans, helping the countries in developing their micro plans, cold chain provision of the cold chain, and communication and the community engagement. In addition to that, you know that every pandemic comes with a lot of rumors, and COVID has also come up with a lot of misinformation rumors. So UNICEF has established social listenings and rumor misinformation tracking systems, and is collecting, analyzing social data to inform programs and to address vaccine hesitancy to improve awareness and the trust among the communities. In addition to that, we are also developing digital enabled interventions to support for the equitable distribution of the vaccines, reducing the GIS-enabled microplans, barcodes tracked vaccines, rapid surveys, trainings of the health workers, community health workers, dissemination of information, and also risk communication and community engagement on that one. And also we are building a resilient health emergency preparedness and capacity of national systems, which is as a one of our goal is that we should not take that this pandemic as a challenge, but you should take it how we are going to build better the health system to address the future outbreaks and the future pandemics. So this is the brief of that one. So in addition to the vaccines, UNICEF is also procuring supplies, treatment, about 500 million doses of vaccines and diagnostics also, that one. So this is how UNICEF is supporting at the moment the COVAX. Thank you.
Thank you for that. What would you say has been the greatest success and the greatest challenge in regard to global immunization throughout the pandemic?
Okay, the greatest, let me start with the greatest. You see that the way this pandemic spread, and the most immediate challenge, it's a new disease. There was no vaccine for that one. So the biggest challenge initially, how we are going to prevent. So the first challenge, they were different. So one on the prevention side is using the preventive measures of hand washing and providing those messages to the people with the lockdowns, how we can spread, stop the spread of the diseases, and if the colleagues who knows about the epidemic curves, how to flatten the epidemic curve. In the same time, the main challenge was how we can develop any vaccine against this disease, against this virus, as soon as possible. And if you know, the normal process of any vaccine development is almost 10 to 12 years with the studies and all those things. So all those things has been squeezed into within a 1 year. And now that's was the initial challenge, and that's the best success that we have on our vaccine within 18 months, or within, I will say, 12 months of period, which is now start using in the countries, different products has been using. So that was the biggest success, the way the manufacturers, the developers has come up with that vaccine development and rollout. So now the next challenge is the rollout of the vaccine. And as I think you mentioned that at the moment, yes, the developed countries has vaccinated, like UK has vaccinated about 60-70% of population, while the low-income countries has not received so much vaccine, and only few percent of the population has been reached with the vaccine. Our target is to reach at least 30% of people in every country by end of this year. And the challenge we got, that the plans we developed and the way that it was coming, that a lot of vaccine was supposed to come from India for those low-income countries. But with this surge in India, the manufacturer in India has their own demand for the local needs, because this is their first priority. So we have no vaccines coming from India for those low-income countries. So we started, the COVAX start looking for other suppliers and those ones. So that's the challenge which we are facing, how we are going to reach. Now, recently, we have many countries who has come up with their donations, and that is one of the vaccine aid request to the UK government also, to give the donations of the doses. Like UK government has pledged about 80 million doses so far, and they have given around 6.2 million doses at the moment. US government has recently pledged 500 million doses by June next year. And they are coming up, and we are working with them to how we are going to ensure that all those vaccines has arrived in those low-income countries. So one is availability of the vaccine. Second challenge, what we are facing is having a systems in place in the country to roll out those vaccines. If you see routine vaccination for the children, there are very few countries we were having the adult vaccination. The first high-risk people for the COVAX are the elderly, the people with the comorbidities, old age people, and those ones, and the health workers. And those are the difficult to reach. In developed countries, you know who are the old people, where are the ones. In developing countries, those systems doesn't exist. So find those people and reach those people is another challenge in those countries. Then, and to reach those children, countries needs funding, money to roll out. With the COVID, with economical lockdowns and all those things, all the countries are facing funding crisis. So that's another challenge which is coming with the countries, how they are going to arrange the funds to make sure that vaccines, once they arrive in the country, it also reaches to the arm of the person. It has been vaccinated. So Gavi has come up, the World Bank, other lot of financial institutions, donors are coming up to provide their support to the countries, but still is a challenge for every country to. And then the funding is one. Then next one is coming, the systems in place, the cold chain. Like some of the products needs very specific cold chain. Like for the Pfizer vaccine, needs a minus 70 degrees cold chain. And minus 70 degrees is not a normal cold chain. We have in some countries where we have Ebola outbreaks, those countries have some of the cold chains which handles minus 70 degrees for the Ebola vaccine, not every country. So Unicef is now working, has recently secured about 400 ultra low temperature cold chains. We are providing to the countries. We are procuring more, and we need much more. So we make sure that Pfizer vaccine can be reached to every country and they're prepared. So there are the different challenges what we are facing. And then another challenge we start facing, when the vaccines start developing, the rumors start coming up that, oh, this, as usual with the previous pandemic, with the polio campaigns, other ones so we have to handle those rumors and misinformation. Then another challenge we faced start of the year with the AZ, some of the products, AZ vaccine, because when they have some of the countries face some of the side effects of the clotting, which was not so much if you compare the benefits of the vaccine. But it was promoted in the media, and a lot of countries in Africa, they said, oh, COVID vaccine has side effects. But people did not realize that it was, I will not say misinformation, it was miscommunication, or it was not a proper knowledge. Because if you see in the public health, vaccine is benefiting much more people than those minute cases of the clotting. And that clotting can happen with any other things. Just not specific with the vaccine. But people were just picking up those ones that, oh, vaccine is not good for us. So those are the challenges we are trying to work out in the community, building the trust in the vaccines and how we can do that. So sorry, I don't want to take much time. So this is the challenge, and it's a lot of challenge. It's every day we have a new challenge. And we are and we say that we are building a ship while we are sailing.
Yeah, no, thank you. That was a really a very insightful kind of understanding, because we've obviously only been experiencing kind of the vaccine rollout in the UK, but hearing stories from different countries. And I was wondering if you are able to share with us anything about how some of the threats that you mentioned have been combated, or you're working to combat them. And we were wondering if there was maybe a specific example from India or Ghana, both countries that participants in this call have spent some time in.
I think India has done a great job. The way that it was spread in India, it was really a nightmare. And with such a big population, that was a major challenge for us. How good. So India was able to, I will not say stop, but minimize the spread so far. Initially it was a lot of spread, and there was a lockdowns and preventive measures for hand washing, population movements and those things. And now they have started vaccinating everyone. So they started initially, as was the WHO recommendation, to start vaccinating all the health workers and elderly, and they reduced the age breakdown, and they have come down to almost 24 years of people, everyone. So India is doing that one. Ghana is also is doing a good work. The only challenge with the Ghana still is not enough vaccine available for Ghana, because India has their own production capacity. So all the vaccine which is coming from the local production is going to the India, the millions of doses. So India is now working on the vaccination, but Ghana and other countries, they are facing still a challenge that whatever vaccines we are getting from the COVAX, we have to do equitable distribution to all the countries. We cannot give to one country or two countries. So Ghana is also doing that one, but still a lot of work has to be done and to reach those populations in Ghana. Over.
That was great, thank you. And just one last question before we move on to questions from the audience, from Azzai Alumni. Do you think that lessons have been learned from this pandemic, and that future pandemics, there'll be measures implemented earlier in order to combat them? Do you think that the world is now more resilient to future threats?
Yes. Immediate lessons, will I say, is from the past, and including this one. What is required to control the pandemics is the social distancing, wearing masks, avoiding public gatherings, and following guidelines, because that helps in spread of the disease, right? So it's not only protecting yourself. Our main social liability is to protect others also. So that's amazing how we can protect others. I will not say that we have built the resilient health system. It is a lot of work has to be done. And because that will be only the building the resilient health system and the primary healthcare is going to minimize the future pandemics. So that's a lot of work is done. During the previous, like if I take the example of Ebola outbreak, there was a lot of talk to build the health system in those countries. But once the outbreak was over, everybody forget that health system and everybody forget that one. So this is a time that even we are handling this pandemic, we start working seriously on the resilient health systems in all the countries. And the resilience cannot be achieved solely through like unidirectional or top-down approach by governments. It needs a community involvement, community engagements. That is the first one. And for that one is a governance, that how countries are supported the scientific evidence and those things, for leadership willing to take all the information we have. We need appropriate financing, which will be a main challenge. And that was a lesson learned from the previous Ebola outbreak, that once there was no funding, it was initially pledged, committed, but once the outbreak was over, the funds were not there in those countries. And to build resilience, you need a lot of funds. So that we will be advocating with all the donor countries, all the developed countries, all the financial institutes to keep supporting the countries for those funding to build. Then also one is building the capacities in the countries, the technical capacities and the human resources. Because without that one, you cannot build a system. And this is what's seeing in this one challenge, that the health workers now to scale up to reach, first target is 30%, but in the end, we need to reach 80% of the population. And to reach those populations, you need a lot of trained health workers, and not only the health workers, but trained vaccinators. Because some of the vaccines you cannot provide by anyone. It has to be trained vaccinator. So building those capacities in those ones of the health workers. Then also to have a medicines and the products which are available. Another challenge what we are seeing and we need for the beautiful one, that we are advocating with a lot of manufacturers, is intellectual properties. Like whoever developer or manufacturer is developing any vaccine or any product, they put a patent label for them. And there's a problem that if you need to scale up, you cannot do that one. For example, I'll give you example, the seat belts. When in 50s, 60s, the seat belt was developed, it was for safety of the passengers in the car, right? So whoever developed, that person, that I will say a word that they did not patent that seat belt. They said it is for the public health, anyone can use it. And now you see every car, everyone has a seat belt, and how many lives we have saved. So this is, we are trying to advocate with all the manufacturers to avoid this, the intellectual properties patent. So if we have developed, if I have developed any vaccine, anyone can use the same formula and start using it. So we can have a big production of vaccine and it can be reached, because with a limited capacity production, it will be a problem. Then also another thing that is a community health workers. I would say that building the resilient primary healthcare, it depends on the community health workers. The community health workers could be the best source of information in the community. They can be eyes and ears. They are the one who, if there's any outbreak is start from community, they are the first one who can pick it up and inform and put a red flag that something is strange is happening, and you can immediately act on that one. Or if you want to share the information, messaging to community health worker. So that community health worker force is a one of the main cornerstone of developing those systems. And I will not say only the community health workers. I will say anyone working in a community. It can be a teacher, it can be a religious person, it can be anyone. Is someone who is in the community who can be eyes and ears of the health systems. Over.
Thank you so much. Sorry, some people were freezing on my screen, but thank you so much for answering those questions with, so much information and kind of really contextualizing where this pandemic has kind of fit in with global health and inequality. So we're now going to open it up to questions from participants. So please feel free to raise your virtual hand or post your questions in the chat. But to get us started, I've had a question submitted from George Rosenfeld, and he's asked, do you think this pandemic will lead to an increase in students aspiring to work in epidemiology and biorisk? Something similar happened post 9/11 with careers in security and defense. Assuming so, what are the most important and neglected areas of field which students should consider?
I will say that epidemiology is not only with the pandemic. Epidemiology is public health. So if you compare, okay, I'm a medical doctor by my degree, but now I'm in public health. But if a medical doctor, I will treat a single individual with a disease. With the public health, you are going to prevent the whole community. So there's a difference between public and that one. Second thing on epidemiology, everyone should know epidemiology is basic. What are the reasons of that outbreak or any disease and how it can be prevented. So yes, it will increase a lot of in the career. It will be helpful, and all the agencies and all the organizations are looking for epidemiologists, and they are looking. That is a kind of knowledge that what are the root causes of the problem, how it can be preventive, and what can be done. And then in epidemiology, you learn every day from the field. It's not a bookish thing. Book is one thing which you learn a basics, but when you work in the field, then you learn different things every day, and you have gained your knowledge, and you say, okay, in that country, that was the issue done, how I'm going to address this one now in this one.
Thank you. Thanks so much. Okay, Mikey.
Hi. Sorry. Hi, thanks for a very interesting talk so far. I'm wondering what your thoughts are on at what point should developed countries, at what point do they say, right, we've been vaccinated enough now, our population is vaccinated to a certain threshold, and we now need to be focusing much more on providing vaccines to lower middle income countries? Because obviously there's always going to be more people who need vaccinating, or you can do the children now, you can do third doses, but there's people around the world who haven't had their first dose. But on the other hand, politically, it's impossible to say, we can't open up the events industry because we're giving out vaccines all the way. Like, people won't be happy with that. So how do you balance that, and what's your position on that?
UNICEF position is same with the WHO on this third dose. Number one, this world is a one village. No one is protected unless everyone is protected. So at the moment, there will be no herd immunity unless everyone has a vaccine and protected. So even like UK, if they have vaccinated 60% people, number one, they still have to vaccinate at least 20% more people or 30% more people. Second thing, even if UK has been, then if others are not, and other thing is the new variants are coming up, which is also a challenge. So everyone has to do them. Yes, our position is that countries should not start with the third dose unless there are a lot of countries who has not been 2% of the population has been vaccinated. So that is an inequitable at the moment distribution. So our advocacy is, and the WHO UNICEF position is, that third dose at the moment is only for those who are immunocompromised in those developed countries, not everyone. If someone has got 2 doses and is at the moment with the current definition is fully protected does not need a third dose as a booster dose, because we need those doses for the people who has not received even a single dose in low-income countries. And it's a huge population. From the COVAX side, UNICEF COVAX, we have targeted to provide 2 billion doses by end of this year. As from the COVAX, because of the shortage of the vaccine, at the moment, we have been able to provide only 200 million doses, almost 10% of that one. With the donations which are coming from the USG and other countries, we may reach 30% of the population to reach with those vaccines, but still not enough. So that's the thing that our advocacy is, that we need to reach all the doses. If the countries we are requesting, the UK also government, and I think the Vaccinaid has already, our UNICEF ambassadors like David Beckham and other ones, they have already signed an open letter to the UK government that if they can provide more than 20% of the doses to the COVAX and to reach for the low-income countries, available doses, because instead of starting a third dose, we are requesting all the countries to provide those doses to those low-income countries through the COVAX, so those people can be reached and be protected. Thank you. And sorry, one more thing, what challenge we are facing is, if you see the recent EU use of these travel policies and the vaccination passports, that's also a challenge which we are facing in the developing countries. Because EU, and I think if Chief Rabbi office can be our advocate also in the EU Commission, European Union Commission, to allow anyone who has received a WHO EUL vaccine or the vaccines which are approved by the NRAs, because currently we are seeing in countries in Africa and other countries, people are reluctant to take the vaccines because they said even if they take the vaccine, they cannot travel to Europe because Europe is not accepting those doses as a vaccination proof. Right. So that is we are advocating that, requesting all the countries in Europe and EU Commission to request to approve all the WHO EUL vaccines. And I will also request all the colleagues here in that one and the Office of the Chief Rabbi to be advocate with the EU Commission to accept all those doses which have been approved by the WHO EUL. Thank you.
I just wanted to ask if you could talk a bit more about what UNICEF can do to target vaccine hesitancy.
Asking what UNICEF can do for the vaccine hesitancy?
Yeah.
This is one of the major component of the vaccine other than the vaccine delivery. As I mentioned before, that we have developed this social media listening and tracking systems. We are developing the messaging. We are using the community health workers in all the countries to convey the messages. So it's the messaging for the prevention and vaccine hesitancy, that the vaccine is safe, is no problem, and addressing those rumors or misinformation which are happening in the countries. So UNICEF uses multiple channels, multiple resources. In many countries, UNICEF is using the religious leaders. UNICEF is using the political leaders, all those ones. There was one issues in one of the countries where it was not accepted by some of the religious people. So we contacted them, we told them that no, vaccine is safe, there's no issues with that one. So that's the thing, that UNICEF is using different mechanisms to reach those communities and address all those rumors. And not only once, because with the tracking of the social media and rumor information, so every day if something new is coming, UNICEF is changing the messaging and the strategies how to address those things.
Can I just add to that, if it's useful, Tilly, just from a Vaccinaid's perspective? So obviously, given we've partnered with the Foreign Commonwealth and Development Office, the Department for Health and Social Care, and also the NHS, addressing vaccine hesitancy was one of the secondary objectives we have from the campaign, and we actually measure that. And we've already done 2 sort of insight dips that are UK population sort of nat rep in terms of the sample size to understand the impact. And what really positively we've seen is that the those within the population who are aware of Vaccinaid, 38% feel more positive towards vaccines than they did previously, and none felt more negative. And for those who weren't even aware of the campaign but were shown it spontaneously, just under 20% felt more positive as a result. So that for us has been a real sort of not a surprise, but a really positive outcome beyond just raising money to support Unicef's efforts within the vaccine global rollout. And obviously is music to the ears of like the NHS, given that's also a key objective of theirs. The other really interesting thing is that we've just had the latest dip of insight actually from the campaign. And actually it's talking more to a much younger and more diverse demographic than it did at the start. Which again is fascinating, and that's obviously a demographic that very proactively the government are needing to target from a marketing perspective to get their buy-in into taking their first or hopefully in some cases their second dose. So that's just a bit of a lens on that. That's useful from a Vaccinaid specific perspective.
That was great, thank you, Sarah. So we're just going to take 2 more questions, one from Aaron, then Lauren's got one in the chat that she'll read out. So Aaron, if you want to go for it.
You semi-answered it just now, but I guess on the subject of anti-vaxxers, obviously a month ago or so in the UK, we had when the government announced about vaccine passes for nightclubs in September, and there was an outcry on kind of drawing the line between our free will of getting a vaccine and is the government becoming a dictatorship. Has kind of any sort of issue both from the government side and from the resident side come into play in other countries you've been working with, and kind of what's your opinion on it? What's your approach to tackling where the government, where people feel the government may have crossed the line?
In other countries, yes. In every country, we do find some of the small groups who are vaccine resistant or hesitant or those ones. So we are working with those groups. We are working with the governments and those ones. There are some countries where, because of this media what I mentioned before, with the very specific one of the product, Azzai vaccine, AstraZeneca vaccine, and there was a lot of hesitancies. So UNICEF designed these strategies. Look, what are the reasons? What are the drivers which are leading to that hesitancy? And then we develop our strategies with the help of the government and other partners to implement and build that trust on that one. So the one what you mentioned is a right. It is more common in the developed countries. In the developing countries, people is, I will not say they are refusing vaccine. There are some like hesitancy, they have some questions. And so what we are addressing those questions and clearing those misinformations and misunderstandings. On the right thing, in developed countries, yes, that is, I think in US, in some other countries, there is a lot of group who thinks is their right. So we are bringing it is not right. Okay, it's my right, but it's also my responsibility to protect the others. If I don't get a vaccine and I get sick and I infect other one, I'm not doing a social service. I'm actually harming my community. So we are trying to work out with those communities that, okay, yes, you have a right, but it's right, it's personal, but you also have a right to protect others and not to harm the other communities, your brothers, your sisters, your neighbors, everyone. So this is UNICEF is working with using the different strategies, evidence based on the evidence, looking for those drivers and looking how we are changing our strategy and the communication.
Thank you so much.
Thank you.
Okay, we've got, I think, 3 more questions. slightly running out of time, but they're all, I think, very interesting ones. So there's one from Ayelet who asks, what processes does UNICEF use when deciding which vaccines to accept and distribute? There have been a number of things in the news about statistics released about certain vaccines not having the efficacy in real world use.
Okay, is no okay. Good question. UNICEF does not decide on the vaccine. UNICEF only distribute vaccines which are WHO pre-qualified, and WHO has a very strict criteria on the pre-qualification. They look on the evidence, they look on the safety of the vaccine, they look on the efficacy of the vaccine, they look all the data, and then they do it. So regular pre-qualification of the WHO is a lengthy process. For emergency, if you must have heard EUL, emergency use. So current COVID vaccines are still under development, are under run. So WHO has another criteria which is expedited in emergency and still following all the strict things on the safety and efficacy. And the vaccines which are being get a EUL certificate by the WHO, UNICEF takes those vaccines. Then on distribution for the COVID vaccine, our goal is everyone in the world get at least 1 shot or 2 shots of the vaccines from any product. Doesn't matter which product, whether it's a Pfizer, is Moderna, or is J&J, whatever is those. Our main goal that everyone should be protected, because all vaccines are safe and all vaccines has a good efficacy. Some are 95%, some is 90%, a little bit up and down, but at least whoever will get a vaccine will be protected. So there's a thing that UNICEF does not decide. UNICEF follows the WHO guidance and WHO acceptance on that one. Thank you.
Thank you, Dr. Mirza. I'm going to bring Dov Boonin into the spotlight to ask his question.
Hey, yeah, thank you for the talk. I wanted to ask on a slightly different topic, actually. Could you tell us a bit more about how you developed your own career? I wanted to ask, and what were the key steps you took in your career, and how did you make those decisions? Yeah, slightly different topic.
Okay, interesting. So when after finishing my medical school, I started my clinical practice, and I joined the public sector, working in one of the rural health center, right? And there, it was mainly as a normal medical doctor. There I was looking a lot of diseases and those ones. So then I got that okay, treating is one, but how we can prevent those things? Those diarrhea, children in the diarrhea, and all those pneumococcal diseases, respiratory diseases. So how we can reduce infection. And then during the public sector, I got transferred to another health directorate, where I was asked to start establishing the first provincial level HIV/AIDS program. From there, then I started, okay, HIV, it was started there, and then we have to develop that, the national program and the provincial programs. And from there, set the public health that, okay, disease is something, but the first is public health. So from there, my interest came up on the public health side. And then I started looking that, okay, what we can do and those ones. So from working in the public sector, then I got admission in the Master of Science in Epidemiology. There was one. And then I started learning more on the epidemiology, because normally in the medical school, they don't teach you epidemiology. It's one course maximum or 2 courses in the undergrad or somewhere, but not as one major thing. So I did my 2 years of Master in Science in Epidemiology. And from there, I started working. I joined WHO, moved to the polio program in Afghanistan. And from there, I started working on. Then, while I was in Afghanistan, I was responsible. I was in the north. You must have heard recently a lot of news from Afghanistan. So the north, what you were hearing in Mazar Sharif, I was based there during Taliban period and responsible for whole of the north. And I was the only international from WHO side in that area, in the north of Afghanistan. So then it's not only the polio, everybody was asking me as a WHO person for all other non-polio things, for the maternal health, child health, so my job was to provide all those technical support and see what we can do that one. So that is, I start developing that one, that from polio to maternal health, and then when the earthquake came in 2015 in Pakistan, I came back to Pakistan, and that was a totally different experience. That there were about 72,000 people died in 10 seconds. That was the earthquake. It was such a big, I don't know if you have heard about that earthquake in 2005 in Pakistan. So there were 72,000 deaths in 10 seconds. That whole cities were just vanished. So reaching, which was cut off roads, and how we are going to reach, then vaccinate the children, vaccinate the people, how to provide the health services. So that is my career has developed. And then in 2006, I moved to Lebanon. And from there to 2008, I moved to Somalia. Somalia was totally different challenge, totally different, like is a complex emergency. So this is how I built up my career from in the public health with the experience from not only vaccine, but other health issues. And like in Somalia, when I was there, we established, it was the first time in Somalia, in the country like Somalia. I don't know, any one of you have a medical knowledge or doctor, anyone? I don't know. This is called BMOC, Basic Emergency Obstetric Care. So this is a one WHO one that the services should be available for a pregnant woman. If she has to deliver and she is in emergency, that service should be available for those emergency obstetric care. So we established almost 14 sites in Somalia, which were 24/7 working. So even if a pregnant mother needs immediate support for the delivery 2 o'clock in the morning, she will have access to the ambulance, she will access to the health services, and in case she needs a cesarean section or any operations, she can be referred to the hospital and can have an operation within that period. So it was not, nobody would expect that thing in Somalia, that you will have those services 2 o'clock in the morning. So the doctor, the midwife, everyone is available and services. So this is, I built up my career in the public sector. Because you know, when you're having the public health, you think broader. You don't think as a one patient that, okay, this is a patient have a heart problem, this patient has a blood pressure problem. You look as a bigger picture, as a community, that how I'm going to support the community and how going to prevent those diseases. So this is my career of, yeah.
Thank you so much, Dr. Mirza. Your career does sound fascinating and quite globalized. Yes. Just building on your answer as well, we had one question from the audience about, given sort of the fragile circumstances in Afghanistan right now, in Haiti with the earthquake, and in Ethiopia in the Tigray region, will this affect vaccine delivery? Will UNICEF need to work with other organizations and other NGOs on the ground to deliver the vaccines? And could you give a little bit more information on sort of vaccine delivery in fragile circumstances?
Okay, yes, we are seeing this challenge in Afghanistan now, in the Haiti. Yes, definitely, it may have an impact. I hope things will not deteriorate in Afghanistan with the new, I will not still say regime, I will say, I don't know, it's not acceptable at the moment, government, whoever the Taliban has taken over. And I was there in the previous regime of Taliban when they were there. So I hope at the moment what they are saying, that they will not stop anything. I hope they go ahead on that one and they will not impact, but definitely it will be some impact in the coming days, because Afghanistan was already facing a challenge in the last 2-3 months with all those insurgents and those things. And we have issues. We are working with the partners in the field, with the NGOs, with other organizations, how we can reach. So UNICEF is there. We are already having a daily calls with our colleagues in Afghanistan, with other partners, how we are going to address. So let's see how the things unfold in Afghanistan in coming days. And we say Haiti, yes, with earthquake, it will be impact. Haiti already has a challenge before with the cholera and other issues. They were very weak health systems. So definitely it will have an impact on both countries. But we have experience of UNICEF working in emergency in those kind of situations. The things may delay a little bit, but definitely we will be able to come up and build up the systems back in normal and start reaching. We may have to change the strategies. We may have to change, more funding will be required, but in the end, it will delay the things, but we will be able to reach those communities in both countries.
Huge thank you to Dr. Mirza and Sarah for that highly insightful and informative talk. I think we've all kind of learned a lot and have, really kind of inspired us for the next part of our event about what we can do. So Azzai, which is the name of the program that we have all been on, taught us that the greatest pillar of our faith is recognition of the fact that every human being is created in the image of God. And I think for all of us here, a key next step of that is equal access to healthcare, and of course, access to the COVID vaccine being of such great importance. So as part of our commitment to social responsibility, we must work together to support the vital work that you are both leading on. So again, a huge thank you for being with us today, and please feel free to stay on for the rest of the session, but we also understand if you need to leave.
Thank you, Laura. Yes, I fully agree, because we should first are human beings. So it's our social responsibility. And also like you mentioned about the Judaism, also like in Islam and other things, that it says that if you have saved the life of one person, you have saved the life of the humanity, everyone. So is first is for us is responsibility as a human being, how we are going to save the lives of everyone. Thank you.
Thank you so much. As Lauren said, that was really fantastic, and I think we've all learned a lot. Before we move on into group work and sort of steps moving forward, I just would like to invite Leanne from SEDEC to share some updates on the work that their partners are doing in association with Vaccinaid in Ghana and India.
Okay, hi everyone. So sorry, just to confirm, we're not actually in association with Vaccinaid in Ghana and India, but we are supporting our partners to respond to the situation in terms of the kind of everyday situation of COVID. And I know that a lot of you have been out to Ghana and India and met some of our partners. So this is really to just give you an update as to what the situation is there and what they are doing at the moment. Dietz is just going to share her screen so that I can show you a couple of photos. I'm going to keep it relatively short because I think we are a bit tight for time. So firstly, in Ghana, for those of you who don't know what the situation has been like out there, overall, they have not been as badly impacted as some other countries, and have been able to stay predominantly open in terms of their kind of like local movement, apart from some short lockdowns in the start at the beginning of the pandemic. They are unfortunately having a kind of a third wave, which has been quite a surge due to the Delta variant, but it's still mainly in the south. And those of you who went to Ghana as part of Azzai will remember that our communities are predominantly all in the north. They are obviously, though, in incredibly rural communities, and that means not only do they have little to no access to healthcare, they actually have very little access even to sanitation in order to prevent the spread of the virus. And a really big issue that our partners have seen the entire time since last March is the issue of misinformation and kind of disbelief almost that COVID is a real issue, partly because, so initially it was partly because it wasn't really reaching those communities. So there was kind of that it was actually like a serious problem. Now there are issues that our partners are reporting around kind of misinformation about the vaccine, partly fueled by videos and things like that coming out from the West that are showing everything from people who are against vaccines to people going to football matches in their thousands, which is causing kind of the idea that actually having the vaccine isn't necessary. There's also fears, as there have been a little bit in the UK, around kind of the potential side effects and also associations with kind of religion and the cultural like of that. So our partners have been kind of integral in the support of the Toulon community during the pandemic. So what you can see in this photo here is them teaching our community how to make something called a tippy tap. So it's made entirely from local materials and pretty much cost-free or like very low cost, like items that they would have around anyway. And it's to provide a way of effectively hand washing in the community. And they built those for their communities, but also particularly outside schools when schools returned. Our partners also worked with the local youth groups to run some radio sessions to kind of give more information about the pandemic. As a lot of you will know, that's kind of the main form of media out in northern Ghana. And then finally, this picture here is of our team in Toulon with PPE that we enabled them to fund for the local branch of the Ghanaian Health Service, which meant that they could have the kind of PPE available for health clinics and schools and things like that. So India, very different story. I'm sure you've all heard a lot about India in the last few months, but it's been pretty bad there from the start. Last year, they went into a lockdown with about 4 hours notice, which not only meant that the majority of our project participants, but also thousands, millions of Indians across the country lost their income immediately. And also the virus spread quite quickly due to migrant workers returning back to their communities because they no longer had a job and unfortunately taking the virus with them. Obviously in the last few months, there's been a huge surge again. It's kind of seen to be decreasing now, but scientists are still concerned that it's not necessarily getting as better as they would want it, and that there will be inevitably another surge. And there are lots of issues, as there are in Ghana, around access to the vaccine and misinformation about the vaccine, and a kind of another layer that is added on in India, as Dr. Mirza mentioned earlier, is that India are manufacturing the vaccine, unlike Ghana, but unfortunately at the beginning they were exporting a lot of that, and now they're keeping most of it quite rightly for themselves, but they have a huge population to get through, and there's been difficulty in terms of accessing the clinics to get the vaccine for our communities, who again are incredibly rural and don't necessarily have the ability to get to a health clinic to have it, or in some cases they've been expected to book it over some kind of smartphone app, which they can't do because they don't have a smartphone. So there's still very much some barriers to it. Because of the immediate loss of income that a lot of our participants face, the main focus that we have had is just kind of responding and enabling our partners to keep our participants alive, really. So you can see here, this is one of our partners giving out supplies of food and medical supplies, well, sort of hygiene supplies, so masks, hand sanitizer, etc. In the most recent crisis, we did also, some of our partners gave out things like sanitary supplies, and some brought kind of temperature things so that when people came to their place for education and things like that, they could be tested. And then if you go on to the second slide, so we also our partners also ran preventative education. So this is one of our partners teaching the women in the community how to effectively wash their hands to make sure that the spread doesn't escalate. And finally, I just wanted to share this quote from one of our partners, because I think it really emphasizes this idea of the fact that we really have to come together as a global community and build back better and like more resilient, and that it's not just going to be over as soon as we're all vaccinated, or as soon as, certainly as soon as the UK is vaccinated. So the pandemic has had and will continue to have a major impact on the health and well-being of many vulnerable groups. Women are among those most heavily affected. Lockdowns have also resulted in increased domestic and care work for women. They are facing high risks of job and income loss, and also facing risks of violence, exploitation, abuse or harassment. Post-COVID, livelihood restoration and education interventions are needed in these villages. So for us, this is going to be our focus going forward, working with these women and these communities to make sure that we are able to provide them with kind of a resilient means of recovery from this. But yeah, I thought that was quite a powerful sentiment. And as always, if anyone's interested in working with us or hearing about more of what we do, you can drop me an email. I'll put my email in the chat, but I better let you guys carry on with the next bit now. Thank you.